Periodontitis is an inflammatory disease that results in clinical attachment loss with the formation of periodontal pockets and the destruction of the alveolar bone. The pattern of osseous destruction is not uniform, but rather variable in nature. Classical indication for osseous resective surgery is where the attachment loss is moderate and where there is minimal tooth mobility. Generally, the surgery is used where there is generalized horizontal bone loss, as opposed to significant vertical bone loss. The continuing presence of periodontal pockets with inflammation will lead to future attachment loss. Osseous resective surgery will eliminate the inflammation through a series of carefully orchestrated steps for recontouring of the alveolar bone and management of the overlying soft tissues. By reshaping the alveolar bone, the gingival morphology is re-established and periodontal pockets are eliminated, providing a normal positive osseous architecture. This allows the patient to maintain periodontal health in the long term. Positive architecture is where interdental bone is pyramidal in form and in a more coronal position to the labial or palatal and lingual bone. You must inform the patient of the risks and possible outcomes of this procedure, including loss of attachment, gingival recession, postoperative sensitivity, and increased mobility of the teeth in the treated area. A comprehensive periodontal and radiographic examination is necessary in order to determine whether osseous resective surgery can be used as a potential treatment modality. Factors to consider include depth of the periodontal pockets, length and shape of the roots, location and dimension of the osseous defects, width of supporting bone, location of furcations, root prominence, and relationship of the intraosseous defects to adjacent teeth and other anatomic structures. After achieving profound dental and soft tissue anesthesia, the typical incision is an inverse bevel incision. This type of incision removes excess tissue and thins the mucoperiosteal flap, which eventually allows the gingival margin to be placed more apically. With the use of periosteal elevators, most commonly a number 9 molt, full-thickness mucoperiosteal flaps are raised buccally and lingually to gain access to the root surface and osseous defects. Ample flap reflections and flap relaxation is important. The flap is extended mesiodistally at least 1 or 2 teeth on each side of the anticipated site of bone removal. Typically, there is pronounced bleeding in the surgical sites. Hand curettes and ultrasonic instruments are used to remove granulation tissue in the defect. After complete removal of the granulation tissue, there is minimal bleeding, and the root surface and the osseous defects can be visualized. Thorough scaling and root planing is extremely important. All subgingival plaque and calculus must be removed with hand curettes and ultrasonic instruments to achieve a root surface that is physiologically acceptable. Next, the extent and configuration of the osseous defects are determined. In this particular case, the osseous defect between teeth 4-4 and 4-5 is a shallow 2-wall defect. The buccal and lingual are present, but there has been interproximal bone loss. There is more significant bone loss on tooth 4-5 mesial. As a result, the crater slopes apically from tooth 4-4 to 4-5. Around tooth 4-6, a shallow circumferential defect is present. There is bone loss around the buccal, interproximal, and lingual aspect of tooth 4-6. If these defects are not eliminated, there is a high probability for recurrence of periodontal pockets. The first step is vertical grooving, which involves osteoplasty of the interradicular regions. Osteoplasty is the reshaping of the alveolar bone to achieve physiologic form without the removal of supporting bone. The purpose of vertical grooving is to reduce the buccal and lingual walls of the interproximal craters, as well as reducing the alveolar housing. This will start to provide relative prominence to the radicular aspects of the teeth. With a long-shanked carbide burr, or a number 4 or 6 diamond high-speed surgical burr under sterile saline irrigation, reduce and reshape the interradicular bone. The buccal and lingual bones are removed between teeth 4-4 and 4-5. The floor of the interproximal crater will become the height of the newly created osseous septum. Interproximal bone files, such as the Schluger and Sugarman files, and small hand chisels can also be used. A similar procedure is performed between teeth 4-5 and 4-6. Vertical grooving is contraindicated in areas with close root proximity or thin alveolar bone. The second step is radicular blending. With a long-shanked carbide burr, or number 4 or 6 diamond high-speed surgical burr under sterile saline irrigation, blend the vertical grooves with the radicular bone over teeth 4-4 and 4-5. In other words, the radicular bone is reduced and reshaped to provide a more gradual and flowing osseous topography. The final contours should resemble the festooning as seen in dentures, where there is more relative prominence over the roots. Thinner alveolar bone allows flap placement to assume a more knife-edged margin and helps in the reduction of probing depth. Care must be taken when blending over the radicular bone because the facial or lingual bone over the root surfaces is often thin. Aggressive radicular blending over the prominence of the roots may lead to irreversible bone loss. On tooth 4-6, osteoplasty is performed on the buccal and lingual aspect of 4-6. This eliminates the craters, achieves a knife-edge osseous margin, and allows the radicular bone to blend into the vertical grooves that were created in the prior step. Vertical grooving and radicular blending comprise the bulk of the osseous resective process. These first two steps can almost entirely be used to treat shallow crater defects, thick osseous ledging on the radicular surface, and incipient and early class II furcation involvements. The third step is flattening of the interproximal bone. This step is indicated when interproximal bone levels vary horizontally, requiring some degree of ostectomy. Ostectomy is the removal of supporting alveolar bone. Because the interproximal bone on tooth 4-4 distal is more coronal than the bone level on tooth 4-5, ostectomy will have to be performed to flatten the interproximal bone. Some of the supporting bone on tooth 4-4 distal is removed with small hand chisels. Indications for this step include one-walled interproximal defects or hemiseptal defects. For large defects, achieving positive architecture may require too much bone removal, thereby compromising the periodontal support of the tooth. In these cases, a compromised osseous architecture, such as flat architecture, is acceptable. The final step is gradualizing marginal bone. This is necessary for providing a well-contoured base for the gingival tissue to follow. The floor of the interproximal osseous crater will become the height of the newly created osseous septum. Therefore, the buccal and lingual marginal bone is resected so that it is more apical than the interproximal bone, thus achieving a positive architecture. The buccal and lingual marginal bone on teeth 4-4 and 4-5 is more coronal. With a long-shanked carbide burr or a number 4 diamond high-speed surgical burr under sterile saline irrigation and hand instruments such as bone chisels and curettes, the buccal and lingual marginal bone on teeth 4-4 and 4-5 is carefully removed. Caution must be exercised in order not to remove excess bone. After the bone removal, positive architecture is achieved. The interproximal bone between teeth 4-4 and 4-5 is more coronal than the marginal bones. For tooth 4-6, The mesial and distal roots of the molar should be treated as two premolars. Caution must be exercised in order not to remove bone in the furcation. Following osseous resective surgery, thoroughly irrigate the surgical site, especially under the flaps, with saline to remove any debris. The mucoperiosteal flaps are apically repositioned to cover the bone at its new level. Closure of flaps can be attained with either resorbable or non-resorbable sutures. The recommended suturing technique involves a continuous sling pattern, as this allows the operator to achieve close approximation between the flaps and the underlying bone. Then, pressure is applied with a wet 2x2 gauze against the tissues for 5 minutes, which allows time for a thin fibrin clot to develop between the flap and bone. This holds the flap in place and provides hemostasis. Application of a periodontal dressing is optional. Bleeding is usually not a problem after surgery, especially if the patient avoids alcohol, hot fluids, aspirin, and aggressive rinsing in the first post-operative day. In the case of minor oozing, reassure the patient that it will stop with time. If major, uncontrolled bleeding occurs, such as if the patient's mouth fills with blood, then instruct them to see a doctor immediately. In some cases, swelling is to be expected. To help alleviate this, ice packs may be applied to the outside of the face over the area of surgery, half an hour on, half an hour off, for the first 3 or 4 hours. After the anesthesia wears off, typically the patient experiences moderate discomfort that may last from 3 to 5 days. 500 to 1,000 milligrams of acetaminophen every 4 to 6 hours as needed, or a non-steroidal anti-inflammatory medication such as 400 to 600 milligrams of ibuprofen every 4 to 6 hours as needed, usually provides adequate control of the remaining pain. Maintaining an adequate diet after surgery is recommended. Chewing on the opposite side of the mouth and avoiding extremely hard or spicy foods is also recommended. Meticulous oral hygiene should be continued in all other areas of the mouth other than the area of surgery, which should be avoided for the first week. Gentle rinsing after meals with a glass of warm water or 0.12% chlorhexidine rinse will be sufficient. Rinsing helps flush out debris which collects around the dressing. The patient should be seen no more than 2 weeks following surgery for a post-operative visit and suture removal if necessary. Optimal plaque control is critical for the long-term stability of the surgical result. In the immediate post-operative period, rinsing with 0.12% chlorhexidine may be used adjunctively to proper toothbrushing, flossing, and/or the use of an interdental brush. Professional prophylaxis is recommended every 2 weeks until healing is complete and the patient is able to maintain acceptable oral hygiene in the surgically treated areas. When osseous resective surgery is properly applied, it is a highly effective mode of definitive periodontal treatment. Although the very nature of this surgical treatment modality induces loss of attachment, it is a predictable method of achieving reduction of periodontal osseous defects, long-term periodontal stability, and will improve accessibility for optimal oral hygiene and home care practices.